I am Dr. Hisham Chalepi from Keck School of Medicine. I am the Chief of Ultrasound at the Department of Radiology. Today I'm going to talk to you about the sonographic features in patients with hepatitis and cirrhosis. All right, today our objectives is to describe the key sonographic findings of hepatitis and cirrhosis. We're also going to discuss the rationale of the sonographic evaluation of liver in the setting of chronic liver disease. Now, whenever you talk about hepatitis and cirrhosis, of course, this all goes under the spectrum of diffuse liver disease. So we're going to discuss how we're going to do our exams and the technique we are implementing in our practice. So the liver is best imaged with the patient in the supine and left lateral decubitus position. You can place the patient first supine, look at the left lobe of the liver in the sagittal plane, and image the liver in different planes, the right, the left lobe, and look at the vascular anatomy as well. So initially you should start with a 3 to 7 MHz curve linear array transducer. Now, the recent development of a single crystal transducers will give you better resolution and ability to penetrate even deeper in the liver and have nice resolution and quality of the image that you are trying to get about liver pathology in diffuse liver disease. The other important thing in this discussion is to focus on one of the important aspects of the exam, which is always look at the liver surface. Now, we look at the liver surface using a high frequency probes. Now, the higher the frequency, with better penetration, as long as you can get that surface of the liver, you don't have to go deep enough, just try to figure out the interface between the soft tissues, the fatty plane, and the capsule of the liver. Image that in the sagittal plane with the highest frequency that you have in your practice to get a better assessment of the liver surface. Now, it's very important when you evaluate the liver surface is to make sure that you either do this with video clips or real-time examination. Otherwise, if you get some angulation of the transducer from the perpendicular to the liver surface, you may falsely simulate nodularity. Unfortunately, the false positive findings will increase as you interpret your images based on still images. So real time is very important to evaluate the liver surface and avoid this pitfall. In addition to that, you always should include color Doppler evaluation of all your patients suspected of liver pathology. Now, this is very important. Even if most of the exam they're going to come to you for evaluation of these patients with liver disease as right upper quadrant without Doppler, you really don't have to have a Doppler order by the clinicians, because most of the clinicians in the practice, specifically primary care physicians, are not aware of specific Doppler study requests for their patients. So the most common exams that are going to come your way and orders are going to be about right upper quadrant. Now, when we talk about diffuse liver disease, you have to discuss the following. First, we're going to talk about hepatomegaly. We're going to discuss hepatitis. We're going to talk about fatty infiltration of the liver. And most importantly, we're going to discuss the appearances of the liver in cirrhotic patients. And at the end of this topic, we're going to discuss the role of color Doppler in evaluation of therapeutic port to systemic shunts. So let's start with hepatomegaly. Now, the problem that we encounter in imaging as radiologists is whenever we deal with a 2D image, quantification of the size of organs is somehow difficult and inaccurate. We know that fact over many, many years. The only way to be able to establish correct measurements of organs in the abdomen, like the liver, spleen, and the kidney, is to invest more time of doing volume measurements, which in practice may not be a practical thing for radiologists and can be time consuming. So we believe that the most reliable measurement is probably the sagittal dimension from the dome to the tip of the right lobe. Now, you make your measurements along the mid-clavicular line. If you do this, and you found a measurement that exceeds 15.5 centimeter, the liver is probably enlarged. Now, it's very important to make into account that healthy individuals, specifically female patients, may have a variation of normal known as the Rydell's lobe that can mimic hepatomegaly. Hepatomegaly can be confidently diagnosed when the liver extends caudal to the right kidney and the left lobe is subjectively of normal size or larger. Now, the question here is, we see there are some question marks here. The question mark here is about the same approach, how you're going to make that judgment in young females with Rydell's lobe. Now, I use this in my practice and I apply it to the patients, to male patients who are suspected of having an enlarged liver. Now, your sensitivity may improve if you have abnormal liver enzymes or liver function tests. Okay, our next topic is to talk about hepatitis. Now, the thing is, in practice, most of the cases of hepatitis that we see is actually, if we talk about acute hepatitis, are those due to hepatitis A. Now, it's very rarely in practice to encounter patients with acute hepatitis B and acute hepatitis C. The thing is, these patients with hepatitis B and C in the acute phase, they really don't have specific symptoms, and most of the time they experience some flu-like symptoms that go away, and we start to see these patients later in the disease when they have abnormal liver function tests or abnormal imaging findings of chronic liver disease. So, in the setting of acute hepatitis, the most common ultrasound finding you would expect to see is most likely hepatomegaly. Now, in addition to that, there are other findings that can help you come to the right diagnosis in the setting, in the right clinical setting, i.e. that the clinicians are suspecting the patient is having an acute problem with their liver. Now, striking irregular gallbladder wall, as we see here, in the setting of acute hepatitis A, all right, is a helpful sign. However, we need to be aware of the fact that this appearance can have a wide differential diagnosis. The wide differential diagnosis here would include patients with congestive heart failure, heart disease, patients with other infectious inflammatory processes involving the gallbladder, etc. So it is not a straightforward, specific, or sensitive sign. However, it may be a helpful features in the diagnosis of acute hepatitis. One point that really helps you pinpoint that the problem is related to hepatitis rather than infectious acute cholecystitis is to look at the lumen of the gallbladders, as we can see on the next slides. The other thing is, if you review the literature, there's a lot of being described in the very, very early days of ultrasound about the starry night liver pattern. Now, I find this finding in practice confusing, as many young individuals with normal liver functions who do not have hepatitis, who come for other right upper quadrant ultrasound for other reasons, have this pattern. So I don't think this pattern is helpful, and I find it again confusing, and I think should be avoided in the process of interpretation in these studies. Now, the other important thing is what else can be helpful in evaluating these patients. Now, hepatomegaly, as we talked about, can also be seen in chronic hepatitis. Hepatomegaly can be seen in chronic hepatitis before it progresses to its end-stage liver disease, as we know it as cirrhotic change. Now, the inhomogeneous, patchy, or diffused increased echogenicity are quite common findings in patients with chronic hepatitis and are related to the amount of fatty infiltration that goes along with the fibrotic changes in these livers. Now, let's review some of the slides and the pictures in the video clips attached. So this is a patient who presents with acute hepatitis A. we have abnormal labs confirming the diagnosis, but at the time of presentation, you can see that the gallbladder has a thick, irregular wall thickening, and you can see how tiny is the residual lumen of the gallbladder in this setting. Now, when you see this out of proportion thickening of the wall in comparison to the residual lumen, I think you should suspect acute hepatitis or any other causes of other than infection, inflammation of this appearance, including congestive heart failure. You can also notice that this patient doesn't have any gallstones. It doesn't mean that they may not have a calculus cholecystitis, but again, given this appearance of the exuberant, irregular thickening of the wall of the gallbladder, the diagnosis of acute hepatitis in the right clinical setting is the one to go for. Now, another patient with cirrhosis, as you can see here, there's cirrhotic liver morphology, there is ascites surrounding the liver, and you can look at the gallbladder. The patient is breathing, and you can see a significant thickening in the wall of the gallbladder. In this instance, as part of the differential diagnosis, this thickening is most likely related to hypoproteinemia associated with liver disease. This patient had an albumin level of less than 1.5, so you can tell that this is most likely the cause of this thickening. Now, a teaching point here is ascites does not cause thickening of the gallbladder wall. This next slide, a still image showing the prominence of the periportal fat, which is described as the starry night appearance seen in patients with hepatitis. But again, this individual or patient did not have any signs of acute hepatitis. The patient did not have any positive labs suggesting acute hepatitis. This patient was presenting for right upper quadrant pain for other reasons, where the gallbladder was contracted, but this finding, I am showing you this example in young patient with the prominent periportal fat, which can be confusing and may give you the pattern of the starry night, falsely giving a diagnosis of acute hepatitis. When we talk about diffuse liver disease, we have to really stop at this little important fact, which is fatty liver or fatty infiltration of the liver. Now, fatty infiltration of the liver results in enlargement of the liver with diffuse increased echogenicity. Now, use the relative echogenicity of the kidneys, provided the kidneys are normal, and compare it to the spleen. The normal spleen is slightly more echogenic than the normal liver. Fatty infiltration is often patchy or focal. Now, spared area in a fatty liver is usually hypoechoic. Now, remember that whenever you see a focal hypoechoic area on a background of a fatty liver, don't ever jump and say, well, there is a mass in the liver, we need to investigate further. The reason is, or the rationale behind this is, if you are aware of the most common locations of the spared areas in fatty liver, like the dorsal to the gallbladder, anterior to the portal vein bifurcation, dorsal left lobe, the caudate lobe, and the falciform ligament, is most likely is a benign process and does not need further evaluation. So let's look at this video clip and see and understand the difference between the echogenicity of the kidney, spleen, and the liver. You can see here that in some individual, when you're scanning the spleen, when the patient is in the decubitus view, right side down, you can see that sometimes the left lobe of the liver can migrate all the way to the left side of the abdomen and reach the spleen. All right, this is what I call like a kissing spleen liver sign. The thing is, if you're not aware of this fact, you can think that there's a mass in the spleen or there's a mass in the liver or vice versa. Now here you can see a good example of the normal echogenicity of the spleen, which should be brighter than that of the near liver. So this is a good way of comparison if you get both of them in the same plane. If you don't have them in the same plane, just take a video clip or a still image of the spleen and compare it to that of the liver on the right side when the patient is supine. That's also another way of doing this comparison. Now, if we move on to the next slide, you can see here that we are managed in the same patient to get information about the echogenicity of the kidney, the spleen, and the liver in one plane. Now, it is unlikely that you're going to see this in every patient in this plane, but in this instance, you can see that the spleen is brighter than the liver and the kidney cortex. Again, the kidney is a little bit maybe less than that to the liver or similar to that of the liver. That's what tells you that the liver echogenicity is normal, and this is what you need to do and compare on the right side when you evaluate the echogenicity of the liver. While both focal fairy infiltration and focal sparing can simulate a neoplasm, an appreciation of the usual appearance and location suffices to avoid confusion. Now, this confusion can be averted if you supplement your study by color or power Doppler. Look at the vascular structures coursing through that area of increased or decreased echogenicity. In other words, fairy sparing or fairy infiltration. If you don't see any splaying or distortion to the course of these vessels, means this is most likely a focal fairy sparing or focal fairy infiltration, depending on the echogenicity. The other thing that you may encounter in practice while you're evaluating the liver is geographic fairy infiltration. Now, what does that mean? It means that either an entire lobe or entire segment are affected. Most of the time, you would expect to see this involving the caudate lobe. Sometimes you may see part of the right lobe, you may see multiple segments involved with the process. Again, the pattern can help distinguishing this appearance from neoplastic process, and again, color Doppler comes to play an important role in this evaluation. One important thing that may help you supplement your confidence and sensitivity for diagnosis of early fairy infiltration of the liver is the use of spectral Doppler evaluation in the hepatic veins. So normally you should expect to see a triphasic hepatic waveform, which is a representation of opening, closing of the tricuspid valve and the atrial contraction. Now, in fairy liver infiltration, you may lose a component of this, or you may lose two components, and the waveform becomes flat monophasic, or sometimes it may just be biphasic, which also should raise the suspicion for fairy infiltration. So let's look at some examples of fairy liver sparing. You can see on this image that there's increased echogenicity of the liver at the level of the bifurcation of the portal vein. But in addition to that, you can see a stripe of hypoechoic area without much of distortion to the vessels, which is most consistent with fairy sparing area in a common location. This is the same patient with more depth to appreciate this hypoechoic area here anterior to the portal vein as previously described on the prior slide, and you can confidently call this fairy sparing area. This is a nice example on this clip to show you geographic fairy changes in the liver. You can appreciate the normal echogenicity of the liver on the right side and the increased echogenicity consistent with fairy infiltration. Now, you need to be aware that sometimes large infiltrative masses in the liver can have similar appearance like that, including liver abscesses. But the clue again is, what do you see on these images? You can see that the hepatic vein is coursing nicely through this part of the liver. No evidence of splaying, displacement, or mass effect or invasion. And you can see how nice the periportal fats and the triads of the biliary and arteries and the bile ducts nicely depicted on this image on this part of the normal liver. Another example of a focal fairy infiltration. You can see the liver looks fine here, but this area in front of the portal vein is having or demonstrating increased echogenicity with some patchy areas of hypoechogenicity. The vessels coursing nicely through it, no distortion. This is most consistent with a focal fairy infiltration. The good news about our experience with ultrasound of the liver is that, as I said earlier, focal fairy infiltration and focal fatty sparing, they follow the same pattern. In other words, wherever you see focal fairy infiltration or sparing, it's going to be the same thing, and vice versa. Now, when we talk about fatty liver, we need to address a very important entity that has a significance and increased morbidity for patients if we don't make the right diagnosis. Now, this entity, known as non-alcoholic steatohepatitis, NASH, or non-alcoholic fatty liver disease, is a condition where severe fatty infiltration leads to hepatomegaly and associated with inflammation and fibrosis. There's also associated increased abnormal liver enzymes, AST, ALT, in these patients. And histologically, NASH, or non-alcoholic fatty liver disease, they resemble those of alcoholic hepatitis. In other words, if you have this histologic pattern observed on a biopsy on someone that has fatty liver, you have to be careful about the possibility of progression of the disease into a chronic liver disease that may lead to cirrhotic changes, portal hypertension, and end-stage liver disease with increased morbidity and mortality. Now, can you make the diagnosis based on ultrasound? Absolutely not. But you can suggest the possibility of NASH when you see severe high levels of increased diffused echogenicity affecting the liver, i.e., whenever you see distortion of the normal biliary and vascular anatomy without appreciation of the pattern of these normal vessels in the liver, this entitles you to the possibility of NASH. However, the diagnosis cannot be made by imaging, and the only way to make the diagnosis is to do a needle biopsy, because you need the histological diagnosis and staging of the disease. Now, in this example, we call this NASH because this fatty liver is showing evidence of increased attenuation of sound through this fatty parenchyma, significant loss of the normal architecture of the vascular and biliary tree anatomy. And the reason why we call this NASH is because this was biopsy proven. Otherwise, what we did say in your diagnosis that there is advanced degree of fatty infiltration of the liver, a potential diagnosis like NASH should be considered in the differential diagnosis, specifically if you see abnormal liver function tests like elevated enzymes. We move on. We're going to talk about cirrhosis. Cirrhosis represents changes related to chronic liver disease and progression into end-stage liver disease. Now, what would you expect to see in cirrhotic livers by ultrasound? What we look for is changes in the shape of the liver, parenchymal inhomogeneity, and most importantly, nodularity of the liver, specifically at the surface. Now, why is that important? It's important that sometimes if you don't pay attention to that subtle early surface nodularity, you may miss an early cirrhotic change. Now, surface nodularity may be the only sonographic sign of this early cirrhotic change, and this may dictate more or advanced aggressive intervention by the clinicians to stop the progression or delay the progression of the disease. Now, surface nodularity is really specific for macronodular cirrhotic change, if you see it. Micronodular changes are not really picked up by sonography, and most of the time the diagnosis is made by pathology, i.e. on a biopsy. Now, what other features you would expect to see with cirrhosis? You would expect to see small right lobe with left and caudate lobe hypertrophy. Once you see these findings, it's a straightforward diagnosis, and most of the time you can see associated other features like ascites and changes related to the portal vein that we're going to talk about in a few moments. Let's look at some of the examples of cirrhotic change. This is a high-resolution ultrasound using a linear probe evaluating the left lobe of the liver. Now, this is a straightforward example because look, in the presence of ascites, your specificity and sensitivity significantly improves. You can see how irregular this liver surface, indicative of cirrhotic change in this patient with chronic hepatitis. Another example, whenever you have ascites, you can really appreciate the nodularity of the surface in the right and left lobe of the liver, and this is improved due to the fact that you're using this ascites as a water window to improve your acoustic signal and identifying this nodularity in the liver surface. But again, in the same instance, you look in this case, the patient has multiple hyperechoic lesions all the way through the liver that has been proven to be HCC in this patient with long-standing chronic hepatitis. Another example of changes that you can identify in cirrhotic patients, in addition to the nodularity of the surface that you can see here at the interface of the ascitic fluid anteriorly, are these multiple hypoechoic lesions scattered through the liver parenchyma, and these hypoechoic lesions scattered through the liver cannot be adequately characterized by sonography. However, all you can say is describe them, and most likely they may represent regenerating nodules, but an HCC among any of these could be a possibility, and further imaging with MRI may be helpful to better quantify this nodularity and these nodal lesions in this liver. Now, one important thing is whenever you look at the liver surface and you start to see some bumpy, lumpy nodularity on the surface with some mimics of masses, like in this instance, which is bigger than 1.5 centimeter, you should include in your report that you are suspicious that this could be a dysplastic nodule, and further imaging with MR or multi-phase CT scan should be performed to exclude the possibility of HCC. Now that we talked about the grayscale findings in cirrhosis and chronic liver disease, we move on to address one of the most important aspects of evaluating patients of cirrhosis, which is the role of color Doppler sonography in this population of patients with cirrhosis. Now, what do we look at is you need to look at everything. You need to look at the portal vein, you need to look at the hepatic arteries, you need to look at the presence of venous collaterals in the abdomen, and it's very important to be very meticulous in the evaluation of these vascular structures. So now the most important thing we look for is we look at the portal vein and we try to establish whether there is reversal, either complete or biphasic, in the portal vein. We look at the presence of collaterals in the left gastric, the paraumbilical, all these suggesting the presence of portal hypertension. Now, it's very important to keep in mind that in a good percentage of patients without advanced grayscale imaging, they may start to show these findings of portal hypertension, which is really important to include your color Doppler evaluation in every right upper quadrant ultrasound in patients known to have chronic liver disease. So what are the findings that are expected in addition to the portal vein findings? We always try to look at the hepatic arteries. The hepatic arteries, we look for a corkscrew pattern, that is reflecting an enlarged arteries trying to compensate for the decreased flow of the portal venous flow. So this can be a good sign that will help you supplement your impression of underlying portal hypertension. In addition to that, an enlarged hepatic arteries in the liver will show higher velocity. In other words, they have higher frequency shift, and you can easily observe this on real time with aliasing patterns suggesting the increased blood flow to the increased arterial blood flow to the liver. Now, the next step you have to look for is you need to look at the hepatic veins. The hepatic veins evaluation, despite the fact that blood flow can still be preserved and going in the right direction outside of the liver into the IVC, you need to evaluate the pattern of the blood flow. Now, it's very important to make sure you don't miss the color evaluation of these veins to look again for aliasing. As a fact, we know that in the abdomen, the veins are not supposed to have color aliasing, not supposed to have high frequency shifts unless there is stenosis in these veins. And this is quite common thing in advanced liver disease and cirrhotic patients where due to fibrosis, the fibrotic tissue on both sides of the vein can compress the veins and create focal area of stenotic segment reflected as abnormal aliasing velocities. In addition, spectral Doppler evaluation of these hepatic veins will help you to supplement your findings, either increased velocities with loss of the normal triphasic waveform. We talked about it earlier in the evaluation of fatty liver. So let's review some of these images and video clips. So if you look at this, I really recommend that evaluating of this physiology be performed in real time using video clips or personally scanning the patient in real time to make sure you evaluate the blood flow to the liver and the portal vein and the hepatic artery. So in this instance or example, we can see that there is obviously biphasic portal venous flow going into and outside of the liver. Look at this changing color from red to blue. And in addition to that, you need to focus also on what's happening next door in the arteries. Look how high velocity aliasing in these arteries adjacent to the vein in this instance. So, although we have partial reversal here, but we know that this patient is having portal hypertension given the fact that the left hepatic artery in this instance is really enlarged and showing significant frequency shift, i.e. aliasing, which also supports the diagnosis of portal hypertension. Now, other findings associated with portal hypertension and which really emphasizes the role of color Doppler is the presence of this large paraumbilical vein going all the way out to the surface of the liver. Now, the thing is, despite the size of this, because of the blooming of the color flow, because of the velocities that you observe here, if you don't apply color Doppler over this falciform ligament, there's a good chance that you may miss the presence of this abnormality, which indicates that the patient is having hypertension. Another example in this patient with a large paraumbilical vein, and you can see it's traced all the way to the abdominal wall, and in this instance you can see it goes all the way north to the chest wall. Now remember that recanalized paraumbilical vein can go north to the chest or can go all the way down in the pelvis, and sometimes some of these patients may present with scrotal varicocele, so you need to know how to evaluate these patients and ask questions about if they have a history of chronic liver disease. Another example here is we can see the other possibility of findings by color Doppler. In this instance, you can see on this video clip that there is reversal of blood flow, complete reversal blood flow in the portal vein. Now notice that the nearby hepatic artery shows some aliasing and its size is almost close to that of the portal vein, which is something you don't see in normal individual. Of course, in addition to that, see how heterogeneous the liver parenchyma, the nodularity adjacent at the surface associated with these findings. All this will fit in the diagnosis of cirrhosis with portal hypertension. Now, if you notice here also that you need to pay attention that sometimes whenever you do evaluation of the portal veins with color Doppler, you may pick just partial reversal of a flow in the mid-segment branch, as in this instance. This patient had a history of hepatitis secondary to ETOH, alcoholic hepatitis, and subsequent cirrhotic change. Now, as I said earlier, we need to pay attention to these big hepatic arteries. The hepatic artery in this instance, the left, and its branches into the left lobe show evidence of significant color aliasing, which indicates enlargement and suggesting increased arterial flow to compensate for the diminished portal venous flow going into the liver. Another interesting thing that you can identify, as I said, with color Dopplers, you can identify the venous scleratus, and in this instance, this patient was referred for evaluation of pre-tips. All right, so the request was pre-tips evaluation. So the plan is to create an interventional suite at tips in this patient. But while evaluating this patient, we managed to identify that the portal vein going into the liver, shunting into the hepatic veins, coming back out into the IVC. So you managed here to avert the possibility for an interventionalist radiologist to go and create the shunt, as the patient is already having an auto shunt, what I call auto shunt in this patient, and there's no need to intervene to decompress the system. It's already spontaneously decompressed. So expect to see these things occasionally in patients with chronic liver disease, portal hypertension, and cirrhosis. Now, the question is, if you evaluate this liver just with the grayscale without color Doppler, you're definitely going to miss this significant finding in these patients. Another example of changes encountered with color Doppler in cirrhotic patients, as in this instance, you can see how the hepatic artery is big, tortuous, and this is what we called it, the corkscrew artery, that tells you that there is definitely significant increase in the arterial flow into the liver. Now, this is really a very good sign to suggest that there's going on some disruption to the portal flow to the liver, because even though you can see still that everything is flowing in the right direction in the portal vein nearby, this large artery suggests that there's not enough portal blood is going into the liver. You can notice here how sluggish this flow in the portal vein here adjacent to the artery. Again, another example showing despite the fact that the portal flow is still preserved hepatopetal, and i.e. going in the right direction, but you can see that this color map and hue is so dark, indicating sluggish flow. In addition to that, look at the arteries we talked about again. Another example to emphasize this fact is the color aliasing, the turbulence, the frequency shift, indicating increased arterial flow to this liver with diminished portal venous flow. Other things that you may encounter in evaluating these patients, if you don't use color Doppler, which obviously you can miss because you can assume all these things on grayscale, maybe bowel loops, and you easily can miss that. But once you flick that color Doppler and look at it, and it's all filling, going back and forth in different directions, the typical appearance of subhepatic venous scleratus secondary to advanced degree of portal hypertension, secondary to cirrhotic changes in the liver. Now, this is a nice example showing that if you have the right settings, you can identify esophageal varices, as in this example with color Doppler as well. Now, without color Doppler, there's no way you'll be able to identify that. There's no way you're going to tell what is there present or not, because this thing will be only identified by color Doppler. So the teaching point again here is a repetition advice that you need to do color Doppler on these patients with liver cirrhosis, even if they just present from the ED or from the primary care physicians or even hepatologist for right upper quadrant ultrasound, not requesting Doppler evaluation. Another example of collaterals. So here we are trying to show another spectrum of the venous collaterals that you can identify, which easily can be missed if you just do grayscale imaging. So this hypoechoic thing adjacent or anterior to the left kidney in this instance would have been thought as maybe part of the normal perinephric fat. However, when you evaluate this with color Doppler, you can see a very large venous collateral in the left flank of the abdomen, suggesting portal hypertension. All right, so now we are going to talk about therapeutic portosystemic shunts in these patients with cirrhotic changes. And you can say that we evaluate those portosystemic shunts every now and then to make sure that they are patent and functioning. And the most important thing that you need to keep in mind is try to avoid evaluating these shunts immediately after being put in. The reason why is most of these are covered stents, and these covered stents will have trapped nitrogen air at the time of the placement and procedures that are still not absorbed by the patient, and may mimic or simulate complete thrombosis, as ultrasound have difficulty penetrating through air and will significantly diminish the accuracy of your study, and erroneously you will definitely give the wrong diagnosis at that point. So the advice is try to not evaluate those prior to 48 to 72 hours from the time that they were put in. So what do you use to evaluate these tips? We know that low frequency Doppler, right, about 2-3 megahertz will be best for imaging these tips. The reason why they're going to be deep in the liver, and the only way to get to these appropriately is via intercostal approach. Now, the tip stenosis, all right, may result in increased or decreased flow velocities. Now, there's a big variation in the literature about what is normal, what is abnormal, but I think generally accepted rule is if your velocity is between 90 and 200 centimeters per second in the mid and distal stent, then the tips is most likely patent and open. A fairly specific but insensitive parameter of stent dysfunction is finding flow away from the stent in the native portal veins. But again, if you see preserved hepatopetal flow specifically in the left portal vein, it doesn't mean that the stent is not functioning. In other words, if you see the reversal in that vein because of the presence of the stent, this will support the fact that the stent is functioning and open at that point. So let's look at some examples. This is a stent evaluation with color and spectral wave Doppler. You can see in part of the stent we have nice velocity coming here, and then we start to see some increased velocities with color aliasing and frequency shift. And we measure the velocity and it's 268 centimeters per second. So this suggests that this is a mid-stent stenosis. All right, another example of TIPS evaluation with color Doppler, and this is the most reliable finding to say that the TIPS is thrombosed is when you do not see flow within the stent by color Doppler. And this is, in my experience, I find this as a very reliable sign that the TIPS is not functioning. But also you have to be aware of the fact that you need to have optimized color Doppler settings before you make this call. And also it's worthwhile evaluating the stent with power Doppler, because power Doppler is more sensitive to sluggish flow, and if you see the same thing by both, most likely this TIPS is thrombosed. Additional thing is some vendors have something called B-flow imaging that can also be sensitive for evaluating of these TIPS and can also improve the confidence of making the right diagnosis about thrombosis. This video clip here shows a similar pattern of aliasing in the mid-stent with narrowed part of the stent here, and this also consistent with mid-stent stenosis. In other words, video clips can help, or real-time imaging with a spectral wave Doppler, which complement each other and help you make the right diagnosis as well about these stents in the liver. As I said earlier, you can use power Doppler in the evaluation and stent, and this is a very nice example of a tight stenosis in the mid-stent here, secondary to a peripheral clot that's creeping to the mid of the stent and resulting in malfunctioning of the stent. a common problem with the TIPS stent is over time the stents can migrate backwards into the hepatic vein. You would like to have the stent on this subcostal image just coming into the IVC, not really extending further to the back of the IVC, just a little bit here. And usually in this example here, as you see, is like it retracted all the way back into this hepatic vein, and this of course needs to be fixed. But if you apply color Doppler, as we can see on the next example here, you can see how nice flow is coming down the jet, and there's a jet phenomenon with aliasing coming through the narrowed segment of the hepatic vein where the stent retracted, suggesting that this is post-stent stenosis. Now, we need to address some of the findings, some of the new applications that are being implemented in the evaluation of diffuse liver disease. Ultrasound contrast material is being studied quite extensively in Europe and Asia, something in Canada, something we don't have access to here in the United States, and we cannot comment much about our experience here, but something that we expect to happen in the near future. The other thing is other software manipulation like 3D evaluation of the liver surface in cirrhotic patients. This technique is best utilized in the presence of ascites. It really does not work without the presence of ascites. It has too much limitations. So if you have enough ascites, it can be helpful. We can see some examples. Now the other thing is other software applications like speckle reduction imaging, which really is post-processing of application of different levels of compounding, can improve conspicuity of diffuse liver disease and evaluation of subtle nodularity as well as focal lesion in these cirrhotic patients. And now this is, and we move on to elastography. This is something that is gaining popularity in the industry in Europe, Asia, the United States. Now a lot of application and studies being done extensively in Europe, not much in the United States. And of course, speed of sound manipulations, where people identify that if you manipulate the ultrasound speed of sound, you can get better evaluation of fatty livers. Some limited experience so far in the literature. So let's take a look at some of the examples. This is a 3D liver surface, and you can see how nice the nodularity of the liver is nicely appreciated. But again, to be able to do this, you need a lot of fluid surrounding the liver to get nice images. If you don't have that, it's really hard to appreciate the nodularity. And as I said earlier, high-res 2D image should be enough to make the diagnosis of surface nodularity. Now, this topic is beyond the discussion of elastography, but in brief, you are using mechanical force induced to tissue, external or internal force. You measure the tissue displacement with either ultrasound or MR. And of course, what we're trying to do here is trying to estimate the tissue stiffness, qualitative or quantitative. Basically, what we're trying to do in the liver is assessment of liver fibrosis. It based on the data published in Europe, and in the United States, it sounds like that there's a future for evaluating of the degree of liver fibrosis. Unfortunately, quantification of masses as benign versus malignant in the liver is quite limited, and there's not enough data to support its use. So this is an example of elastography. What you do is you pick a region of interest, and you identify that region of interest, and based on a scale that you identify here, it will tell you how stiff the liver parenchyma, and whether it's soft or stiff, depending on whether the patient is having fibrosis or fibrotic changes in the liver. And you can see here there's examples. This is examples from studies done in Europe, quantifying the biopsy score and the correlation of the finding of the degree of fibrosis in the liver. Now the system will give you or measure the speed of sound, and actually will also estimate for you the degree of stiffness based on the kilopascal measurements. And this is a very intriguing way and a very promising technique. It has been improved in multiple countries in Europe as evaluation of the degree of fibrosis and potentially avoiding an invasive procedure like fibrosis, like biopsy. So this is the fibrotic score that everybody is using now in the degree of pathology quantification of the degree of damage in the liver. And you can know it goes from 0 to 4, and of course 4 is cirrhotic change. And the whole point of this evaluation is try to halt the progression of disease when it's at this stage between F2 and F3. In conclusion, as you can see, ultrasound is an excellent tool for the evaluation of diffuse liver disease. It still has unprecedented advantage of real-time imaging, particularly blood flow dynamics, which gives ultrasound the advantage over CT and MRI. And thank you for your time.